All right, good to go.
All right, thanks so much. Good afternoon, everybody, and thank you guys for having me today. I'm Catessa Howard. I'm our lead antimicrobial stewardship pharmacist for the W Medicine Health System. And I've been at WVU for almost 7 years now. Today we are going to be talking about a sticky situation, choosing duration of therapy for Staph aureus bacteremia. Next slide, please. Just a couple objectives of today. We'll briefly review the role of antimicrobial stewardship in determining durations of therapy, and then we'll go through some literature assessing durations of antimicrobial therapy for Staph aureus bacteremia. But before we get started, I do have a couple questions for you guys. So if we can go to the next slide, it's my first question. The first question I have is, what would be the standard treatment duration you would choose for a line-associated MSSA bacteremia? And you can feel free to put these in the chat. Would you do 7 days, 14 days, or 21 days? I see a B, 14 days, coming through. Lots of Bs. Okay, so lots of 14 days. Great, great. Okay, and we'll go on to the second question I have on the next slide, which is, what would be the standard treatment duration you should choose or would choose for a native vertebral osteomyelitis with an associated MRSA bacteremia? Would you choose 14 days, 21 days, 28 days, or 56 days? Okay, great. I see a lot of C's coming in the chat here. All right, so keep these questions in mind. We will come back to them at the end of the didactic portion as well. So if we go to the next slide, I always like to start off every talk I do with going over our W Medicine stewardship motto, and that is using the right antimicrobial for the right bug at the right dose and route for the right duration. So today we are focusing on the duration of therapy, and stewardship has a huge role in duration of therapy. Often some of the biggest impact and biggest recommendations that we make are surrounding durations of therapy. Often we cut those durations down to shorter durations, choosing the shortest, most effective duration that we have in the literature. But sometimes maybe even the more impactful recommendations we make are lengthening duration of therapy. And often I find myself doing this in certain Staph aureus bacteremia cases, which we'll talk through a little bit of the literature about why that is coming up. So if we go to the next slide, I always love to show this when I do a talk on durations of therapy. This is directly from a website that is ran by Dr. Brad Spellberg. If you work within the W Medicine system, you may have seen a Grand Rounds presentation he did, I believe, about a year ago. But shorter is better is a huge phenomenon taking over, and there's a lot of randomized control trials coming out showing that short durations are just as equally effective as long durations. But what about Staph aureus bacteremia? So there's really not a lot of literature around shortening the durations that's been published yet. We'll talk about a few trials that are ongoing. But I do have a highlighted box here that specifically calls out bacteremia non-Staph aureus. So often we don't really know the answer if shorter is better in this situation yet for many cases. But we're going to go through the literature that is available. So if we go on to the next slide here, I'm going to talk to us a little bit about Staph stats. So Staph aureus is the leading bacterial cause of death in over 130 countries with around a 27% 90-day mortality rate for those that have Staph aureus bacteremia. So it is one of our more virulent infections and something that we definitely see a lot here if you're practicing within the state of West Virginia for sure. Moving on to the next slide, common infectious foci. So often, I like this meme because the diseases that's caused by Staphylococcus aureus is ongoing. Sometimes it's just, if you have a patient with Staph aureus bacteremia, if you image them, you'll find infectious foci in many different places. but commonly we find this in endovascular structures such as endocarditis, or maybe even if our patients have endovascular implants, such as LVADs or pacemakers. Osteoarticular sites are often common as well, so prosthetic joints and native joints, all the like. Pulmonary infections, not as common, but we do see those. And up to 20% of patients with Staph aureus bacteremia have an unknown source. So sometimes we may not even know where it's coming from. A fun fact I always like to put in about Staph aureus, and something I've intervened a lot in the stewardship setting, is if we find Staph aureus in the urine, we should be prompted to obtain blood cultures, because up to 30% of patients with bacteriuria with Staph aureus will be bacteremic as well. So we've implemented a few things here, specifically at Ruby Memorial Hospital, prompting urine cultures when Staph aureus is in the urine. I know some of our other facilities have implemented this as well, just as an education piece. Moving on to the next slide. The reason why staph is so sticky in such a sticky situation is that it actually has a lot of ways it can evade the host immune system and cause bacteremia and cause invasive disease. So this is actually I'm not going to go through this in depth just for time's sake, but I did want to put this in here. And this is from a review article that was published in JAMA actually just yesterday on Staph aureus bacteremia, but it goes through the pathophysiology quite nicely, I think. So when Staph aureus breaches the skin or the mucosal barrier, it evades a lot of the things that typically keep pathogens out of our system. So it evades neutrophils, it evades destruction by B cells and T cells and monocytes. It has the ways to survive intracellularly through inhibition of oxidative stress mechanisms. It goes through various reduced phagocytosis via inhibition of different C3 mediated opsonizations. But then ultimately, when it evades all of that and it gets in our bloodstream, it attaches to our host tissues, so heart valves, bones, implanted devices, and forms biofilms as well, which can really make it even harder to treat than it already is. So if we go to the next slide, this goes through a bit more on how those biofilms are formed, which in these biofilms, they kind of form these little colonies of different pockets of infection. And within there, Staph aureus replicates at even a different degree than it does when it's in our bloodstream circulating around. So this just makes it a lot harder to treat. And biofilms we often find on implanted devices, such as implanted prostheses of joints, valves, things like that. And then also it can form many abscesses as well. So these are just ways that once staph gets into the body, it can really work, it can outsmart our own immune system and work to form these other biofilms and abscesses that make it even harder to treat, and often have we see bacteremia persist for longer than we do in other bacterial bloodstream infections. So moving on to our next slide, that kind of takes us to how long do I treat Staph aureus bacteremia? So this applies to MSSA and MRSA. And when you see here, we have 2, 4, 6 weeks. And when do we consider maybe potentially over 6 weeks of therapy? So going to our next slide, the first thing that we have to do when we have Staph aureus in the blood, and once we've identified the source of the bacteremia, is determining the definition. So if we look in the IDSA guidelines, I believe they are from maybe 2011 and specifically focus on MRSA, it goes into a definition of uncomplicated and complicated. So uncomplicated, they specifically define as endocarditis excluded, no implanted prostheses, follow-up blood cultures obtained 2 to 4 days after the initial ones are negative. Patient is defervesced within 72 hours. And they also say potentially in community onset. These cases may not always be uncomplicated. And when you have someone admitted with a community onset Staph aureus bacteremia, often I have this in italics because often they may need to be considered complicated, but they're kind of in between the two. If you have an uncomplicated Staph aureus bacteremia, the duration of therapy is 2 weeks. And complicated is anyone not meeting the uncomplicated definition, and that's where your duration of therapy is traditionally 4 to 6 weeks of therapy. If we go to the next slide, though, we'll see that there's a push in newer literature to move away from this complicated and uncomplicated definition into a risk category. So low risk, high risk, and then maybe like a more indeterminate risk, Staph aureus bacteremia. So our low risk, you can see here, I'm not going to go through all of these and list these out, but they're very similar to our uncomplicated definition. They talk about predisposing host factors, which are things like immunocompromised states and IV drug use, and they go through a further list of that. And then high risk Staph aureus bacteremia they define as risk factors or suspicion for infective endocarditis, any clinical signs of metastatic infection, or some of those more complicated foci of infection that I talked about in some previous slides. If a patient has a history of IV drug use, and if they have blood cultures beyond 48 hours. The other thing that they point out in both of these is timely antibiotic start. So if you have a delay in starting antibiotics, that would push you more into a high risk category. And then the durations of therapy are 2 weeks for low risk and 4 to 6 weeks for high risk. But I want to say that uncomplicated or potentially low risk Staph aureus bacteremia is quite rare. I think one of the trials that's been more recently done, I think it was published last year actually, that really highlights how rare uncomplicated Staph aureus bacteremia is the Sabato trial. So this study was conducted over 7 years. And the reason I want to point it out is it's a great study that looks at switching to early oral therapy in low risk. But the one thing is that over the 7 years, they actually excluded 92% of their patients because the patients did not meet the eligibility criteria of uncomplicated, which they defined as if they had a deep-seated focus of infection, septic shock, prolonged bacteremia, so a positive blood culture obtained greater than 72 hours after starting appropriate therapy. They had an intravascular catheter that was not removed, or a history of MSFA or MRSA bloodstream infection in the past 3 months, injection drug use, immunodeficiency, prosthetic material, anything that really would make them complicated or high risk even. So just showing that thousands of these patients were excluded, and they ultimately only included, I think, around 200 and some patients over their time period. And previous data that was published before this demonstrated about 23% of patients actually meet criteria for uncomplicated Staph aureus bacteremia. Moving on to our next slide. Oh, sorry.
I'm sorry. You have a question in the chat. It says, what if obvious source like SSTI at different locations, but they have a prosthesis? Would you still do 4 weeks?
Hi, Jacob. That is a great question. I think that in that case, and I'll definitely let our physicians on the call weigh in as well. I think it would just have to deal with the clinical course of the patient. I think in those situations, the prostheses would have to be examined very thoroughly, whether that's through imaging, with, CT, MRI, or echo if it's a heart valve, and then how quickly they clear therapy, or clear their blood cultures, how quickly they defervesce if they had a fever. I think it really goes into the clinical course of the patient. If I'm looking at this patient, I typically err on the side of caution and would do 4 weeks of therapy. But I think it depends on the patient, and every patient has to be treated how they present. But I'll definitely let the physicians weigh in on that one too.
I concur with you. So this is one of those areas where you would use clinical judgment. If it is a very transient Staph aureus bacteremia and the patient was started on therapy very quickly, you might look at the shorter duration. But if this has been, especially if it's a recently placed prosthesis, most of us might err towards doing the 4-week course.
Thanks so much, Dr. Sawari. Yeah, great point. And I think this is a good point too. This is a situation where I think a lot of us would feel comfortable with, a bit of IV and then finishing up with oral if we choose the 4 weeks of therapy. But great question, Jacob. Thank you. All right. So kind of going into that, data to support duration of therapy in uncomplicated Staph aureus bacteremia is also rare. So there's a paucity of data in this. I really like any reviews that Clinical Microbiology and Infection points out or publishes, because I think that they do a really great job of systematic reviews. But I like this one. It looks at long versus short course of antimicrobial therapy for uncomplicated Staph aureus bacteremia. And I just wanted to point out the conclusion of this is that sound evidence that supports any duration, short or long, is lacking. And out of all the studies they went through, there were no randomized control trials in this setting. So I think that this is just something that we have to keep in mind, and why it's so important to take every patient that we see with uncomplicated Staph aureus bacteremia, kind of work them up individually, and we can't just blanket say, 2 weeks or, whatever time period they need, given the paucity of data that's out there. And speaking of maybe even, we say 2 weeks, where does that come from? I just said that there's not a lot of data. If we go to the next slide, I'll show that, anything less than 2 weeks of therapy, the previous data suggested that this was associated with an increased treatment failure. However, I do think that the STAB7 trial, it's an ongoing RCT. I believe this one's being conducted in Denmark. It's aiming to enroll around 280 patients to look at on day 7 of therapy. They'll randomize them to complete therapy or finish out for 14 days of therapy. And they'll exclude anyone with complicated Staph aureus bacteremia. And then patients are followed for 6 months after they complete their antibiotic course. So I think that this will give us a lot more insight into how we should actually be treating these patients if 14 days is the standard, because RCTs are the best way to look at these things. So that, going on to our next slide, a lot of questions I always get, especially from a stewardship perspective, are 4 versus 6 weeks for complicated Staph aureus bacteremia, and which one do you choose? If you can't tell, I like emojis and memes, and that kind of leaves me shrugging often. So really, I think that if we go to the next slide, it's really selected at the provider discretion based upon the clinical course and the source of the Staph aureus bacteremia. I think that this, often it's just depending on how the patient is doing, what their source is, if there's source control, and various other factors that have to be taken into consideration. Once again, there is a trial ongoing. It's called the SAFE trial. This is actually going on in the Netherlands. It's a non-inferiority RCT that's comparing 4 weeks versus 6 weeks of therapy in adults, specifically with MSSA bacteremia. I will say our European colleagues are very pragmatic, but they do not have a lot of MRSA, unfortunately, but they are going to be studying this with MSSA bacteremia. So I think that this will give us, at least it'll be the first randomized, controlled trial looking specifically at 4 versus 6 weeks for complicated Staph aureus bacteremia. Moving into our next slide, when do you consider potentially over 6 weeks of therapy? And something that comes to mind for this for me is native vertebral osteomyelitis. So there was a trial published, I think, back in 2015 that looked at 6 versus 12 weeks of therapy. And they actually called out in this, they found that 6 equals 12 weeks. So historically, we do 6 weeks of therapy for osteomyelitis. But in this study, they said that, you could not extrapolate this to MRSA, given that they only had 5 MRSA. They only had 8 patients with MRSA in the whole trial, 3 in the 6-week group and 5 in the 12-week group. So they said, while we said that 6 weeks is equal to 12, maybe MRSA we're not too sure about. And there's some observational data that says maybe 6 weeks is a bit better for MRSA. If we go to the next slide, this points this out. And this is, once again, this is observational data that's been published, but you can see here when they compare the different durations of therapy of 4 to 6 weeks, 6 to 8 weeks, and then 8 weeks, that there is a decreased relapse rate. But if we look at these numbers and the actual figure, these are small numbers. There were 36 patients total in the 8-week arm. 8 patients total in the 6 to 8 weeks, and only 12 patients in the 4 to 6 weeks who had MRSA hematogenous vertebral osteo. But just something to keep in mind. I think in practice, in my time, I've seen 6 weeks, I've seen 8 weeks, both selected, once again, kind of just depending on the patient-specific factors. So going to our next slide, what is day 1 of therapy? This is documented clearance of blood cultures or date of source control, whichever comes last usually. And then just one plug on our next slide for repeat blood cultures. Even a single positive culture after starting therapy is a poor prognostic sign. And then, that's why we always recommend two sets of blood cultures every 48 to 72 hours until we document clearance with Staph aureus bacteremia, because it does like to persist and it has such a high mortality rate. There's sometimes you may even consider repeating blood cultures again once you do achieve clearance in high-risk patients due to the skip phenomenon, in which we see blood cultures return positive again. That's a bit of a gray area, but it is something to be aware of. So for time, I'm not going to focus on this, but here are some treatment options for MRSA and MSSA bacteremias. This is not all encompassing, and this is these doses are assuming normal renal function, but these are just some different treatment options. I would like to just call out for MSSA, avoid vancomycin due to the increased risk of mortality when compared to our anti-staphylococcal penicillins and cefazolin. And there's many options you can choose for definitive therapy, either oral agents or our long-acting lipoglycopeptides. Happy to answer any questions regarding this after our session today, if anybody has any. But to round this out, I want to go back to our original questions. So the standard treatment duration you would choose for a line-associated MSSA bacteremia, most of you chose B, and that's correct. So we didn't specifically talk about line-associated, but that would be more in that uncomplicated category, particularly if all other of the uncomplicated and low-risk criteria are met and the line is removed. So that would be 14 days would be a standard therapy for that. And then for our next question, I didn't put 6 weeks on here I guess I did put 6 weeks up to 28 days. I put 8 weeks on here because, this is a situation if you have an MRSA bacteremia with native vertebral osteo, you may choose 8 weeks of therapy in this patient, depending on your patient's status. And that is all I have for our didactic portion today. I appreciate you guys listening.